Hello, everybody. Thank you for joining us for the WOW presentation of successful passing of your pelvic floor patients. I'm Mary Kleiss, and Heather Dunphy is our other team member for the pelvic floor therapy group at ActivePT. Oops, there it goes already. There. So a little bit about ActivePT. We are a private physical therapy clinic in southern Minnesota. We have 7 locations, and our main goal is to help our patients reach their goals. So I think that this is a little bit about what makes ActivePT really special to work for and for patients to come and join our family. We have some amazing values and truly care about making life better for people. This is a little bit about Heather and I. We both are parents. Mine are grown daughters, and Heather's are a lot younger. We both were trained at Mayo Clinic, and we both have been trained in pelvic floor evaluation and treatment through Herman and Wallace. We each have kind of a passion for helping people to improve their lives, and Heather has done additional training in pregnancy and postpartum, and I have done additional training in pelvic floor implications for runners. So today we're going to talk about pelvic health conditions that are treated by pelvic floor physical therapy, talk about some screening questions that you can use with your patients, and appropriate language that you might want to remember when you're asking some of the delicate questions. I have some screening resources in here as well. If you're not comfortable using the words, you can just pass them a piece of paper. Also recognize cases to pass to pelvic floor PT, as well as how you can describe to the patient what to expect from their visit. And then finally, I'll share with you some of the treatments that we use and some research and some of the outcomes that we've had with our patients. So some of the pelvic health conditions are listed here. I know you can read, but specifically those patients that you're treating and you can't get the hamstring pain or the deep gluteal pain or back pain that just hasn't been getting better, consider screening the questions if you haven't already asked them. Abdominal, groin, pubic, coccygeal, SI, pregnancy related, obviously. Some people just come in and they say that they've got this pressure in their pelvis and they don't know why. It almost feels like menstrual cramps, or maybe when they're running, they feel a little bit more crampy. There are certain pelvic conditions like endometriosis, surgeries, pelvic organ prolapse, and scar tissue restrictions. We can't make the endometriosis better, but we can help them deal with the pain that is provoked by that. So if you have a pelvic floor tension, that can kind of throw gas on the fire of endometriosis and increase the pain that you're experiencing. And then the ones that you would expect, stress, urge, mixed incontinence, we can help people with those depending on what the reason is, but many times we can help people. And then words that you can learn, painful sex, we can help people with that. We can help people with the pelvic floor tension that comes with menstrual cycle. And then if you have pain with urination, there sometimes is a medical explanation, but we learn how to screen for that. And we sometimes can help people through pelvic floor PT. So for these people, I want you to consider assuming that they're dysfunctional unless you know otherwise. Risk factors include impact exercise, back pain, SI joint, lower extremity issues, like especially hip weakness, obesity, eating disorders, having a baby, previous pregnancy. General population, the research varies, but 25 to 45% of women have some sort of pelvic floor dysfunction. So ask every other person and see, ask them the questions. There is an association shown in research between low back pain and incontinence. Female athletes up to 80%, depending on their sport. And it's a barrier to exercise, which is a real problem for us because we're trying to get people more active. And it's underreported. Half of adult men, quarter of adult women, and in one study there were, of the people who had incontinence, 92% didn't talk to anybody about it. So these are some things that you can say. The pelvic floor is important for these things: breathing and pressure regulation, bowel and bladder function, core and pelvic stabilization, sexual appreciation. If you just introduce it like that and say, have you had any changes in bowel habits, incontinence, constipation? Do you have any leaking peeing? These are some of the ways that I ask people. Are you able to hold it? Do you have leaking with holding it? Do you have leaking with putting the key in the door? That's kind of an urge incontinence. Do you notice it with getting out of the car? There are certain triggers that people have, and we can help them with bladder education to help with those symptoms. And then also the incontinence that comes with weakness, discoordination, we help people with that as well. Do you have the heaviness or pain during or after sex? These are all a lot of the symptoms that people will come up with. And if you're concerned about any of it, just ask us to come in when you're seeing a patient, or send them over to us when you're done. This is an incontinence screening questionnaire that was created just to quickly ask the same questions. If you don't want to ask the questions, use a form. There's also the pelvic floor distress inventory. It's a lot longer, but it can be helpful for identifying patients. Pelvic floor impact questionnaire is an outcome measure that we use, as well as something you could just provide to the patient to see if they have those problems. And then while you have the patient in front of you, recognize the past. Like if you have hip pain that's not progressing, these are some of the cases that I have seen that you guys have sent me, or that I've noticed of my own patients. Obturator internist and pelvic floor was hypertonic with this one. And the minute I did 2 sessions internally, we were able to get back to their other problems that they were having with the piriformis and with external treatments. Coccygeal pain, pelvic floor hypertonicity, especially it was the coccygeus and the levator ani group. I'm not going to go into all the anatomy, you guys can look it up, but hamstring and ischial tuberosity pain can be obturator internus. Pubic symphysis pain was just overall hypertonicity. And then incontinence can be hypertonicity, but then also it can be just poor activation or poor coordination. They might have really good strength, but they don't know how to activate it. And then low back pain, core and pelvic floor lacking coordination and strength. Sometimes it's tight, sometimes it's weak. It can be a number of things. And then I asked Heather for some thoughts. She said, same thing, deep gluteal pain resolved after 2 sessions and then worked on other symptoms they had. High hamstring strain, 4 to 5 sessions with a break. Now they're at 1 out of 10 pain and only occasional. Low back pain was related to core weakness and poor coordination. And then to help, she shared with how to help with PASS to the physical therapist, share the background of the patient, what you've already worked on, thoughts about why it might not be working. And then to the patient, just say, I'm curious about whether there's a pelvic floor involvement. We have a specialist at our clinic, or a couple of specialists, whatever, and then help them understand what to expect from their visit. So educating the patient that pelvic health specialists are trained to evaluate and treat, and we assess posture, movement, breathing, and then numerous muscles, nerves, connective tissue in the same way. We use palpation, same way I would check your shoulder. It involves an external and often internal evaluation. There's no speculum and there's no rush or stress, because at least 1/4 of people who have pelvic floor dysfunction have had some sort of trauma. And I see a lot of, just clinically, a lot of mental health coexisting conditions. They'll undress from the waist down and they're covered with a sheet. And then we do a muscle assessment for tenderness, tension, strength, and coordination. And then we use a private room, obviously, individualized plan. And then the patients can talk to one of us either in person or on the phone or a video visit if they have questions or concerns about it. I always tell people that they can stop it at any time and we can check something else, right? Like if they're feeling uncomfortable, I say use your words or raise your hand, because I never want them to feel like I have to do this right then. I really want it to be guided by them and that they can feel comfortable. So some of the treatments we use, a lot of neuromuscular reeducation. The cartoon at the right shows how the diaphragm descends to allow the inhale of breath into the lungs. And the pelvic floor at the same time has a reflexive relaxation to allow for no change in intra-abdominal pressure. So we start with breathing with everyone because it helps get the range of motion. And in the same way you wouldn't treat shoulder with strengthening before you had the range of motion, you're not gonna really treat this as well. We want a reflexive activation with a cough, sneeze, or a laugh, so we can help retrain that. And then voluntary activation, we train 3 different ways, coordinated with breathing. So inhale, relax, exhale, contract, and activate pelvic floor. There's quick contractions, and when I say quick, I mean like it's about a second. So it's a contract, relax, and both are really important. So I often will start with, okay, fully relax, now contract, relax. Because if you don't relax, it's like trying to squeeze a closed fist and it's not gonna do much. And then we do endurance holds so that you're able to hold during activity, and kind of a goal being 10-second holds. And then voluntary relaxation, that's kind of all of what I've been talking about. Can you voluntarily relax it? And some people, after doing a few contractions, have a really hard time letting go. And then after we get that coordination, we move into activation with their goal-specific training. So if their goal is to do CrossFit or weightlifting, then we start activating and applying it to that. If their goal is to not pee when they get out of a car, then we take that movement apart. Running, same thing. Other treatments, we do pin and stretch, myofascial release, trigger point release, scar tissue mobilization, in the same way that you guys do, but just in a little bit different way. We can't really see sometimes. But also, I have seen recently several patients that their abdominal scar, when I pull that or mobilize that, they're getting shooting pain into their pelvic floor, or even just a referred pain into their pelvic floor. So keep that in mind if you have a patient that has had any abdominal surgery, or even I would say lumbar. I mean, why wouldn't it all? I think that fascial connection is really not well understood. And then we do bladder education and training, bowel education and training, a lot of pain neuroscience education. And then at home, we teach them some things that they can do with yoga poses, stretching, and then the pelvic floor muscle, that's what PFM stands for. Training, so at first we start with down regulation. Can you get it to relax? And then we go with the training of activation. And then these are finally, I didn't realize just how people maybe hadn't seen this before until I was having a conversation with one of the other PTs. But these are some products that pelvic floor therapists use for training at home. So if you see the kind of snake looking thing, that's a wand that's used for internal treatment of trigger points or soft tissue work internally that a patient, we can teach them to do that at home. There are some that vibrate and some that don't. This specific one is silicone treated, so it's a little bit softer, and they also can be pretty, like a harder plastic or based product. And then down below that are the 4 different sizes of, they're called dilators. And these are really important for training after radiation therapy, because you can get tightening of all connective tissue, and cancer patients who have had radiation to the pelvis sometimes have difficulty regaining their vaginal size. So essentially you start with the smallest, which is about the size of my pinky finger, and then they are able to gradually progress up until their goal size, which for some people is a tampon, and for some people it's the size of their partner. And then on the right, I don't use these very often. They're exercise weights, but patients ask me about them all the time. And I have seen more people come to me with pain because of these, so I don't often use them, but they would be helpful for someone who has regained their ability to control it, their relaxation, and then now they want to get to lifting weights. And some of the, I think like those athletes that are really trying to do a strong power lifting would benefit from these. But I actually have heard about people using them for even the earlier training to gain strength. And then just some research that might help trigger your ideas while you're in clinic when you're seeing patients. Chronic pain, especially back pain, is associated with incontinence. Urinary incontinence, actually, there's an increased risk of back pain. So we go back and forth. That's why I think it's really important for pelvic floor therapists to be orthopedic, have an orthopedic background, because I think sometimes pelvic floor therapists tend to be vagina-centric, and we just don't think about the rest of the patient. And so women with low back pain, ages 17 to 45, 78% of that group had urinary incontinence. And then another study had low back pain, 57% had pelvic floor complaints. So, so this one are just some ways that you can contact Heather and I by email. Visit us on our website, or you can request a screening appointment for your patient or for yourself. And there's our office phone number on the bottom. So now I will open it up for questions from the group. So you can unmute if you have a question, or this group that's in the clinic can ask me anything. Happy to entertain questions. Yes.
You talked about reflexive activation. I was just curious what that looks like on your end for trying to retrain that.
Yeah, so reflexively, the pelvic floor should contract and have a lift when you cough, sneeze, or laugh, when there is an increase in intra-abdominal pressure, so that you're not pushing downward and outward and having that incontinence event. So for me, when I have the gloved finger, I should feel a squeeze around my finger and a lift, and then you can cough. So I have someone turn their head and cough. And in a functional pelvic floor, they're able to maintain the squeeze and at least maintain the location. Maybe it's not maintain the squeeze, but it's not pushing my finger out. That's what that looks like.
Okay, thanks.
Yeah. Any other questions? Thank you for your attention. I know that I only have a couple more minutes.
With people who are lifting specifically, are you going, how do you reproduce that in the clinic here if it's only with heavier weights downstairs?
So that is I look forward to working with someone that is doing that. So far, I have only worked with people who are doing the lighter weights, and they've been able to manage it on their own.
Like Steve said, that's pretty much expected that you're going to urinate on a heavy lift.
Yeah. So what I expect that I would do, I would get them to the point where they can do, the power lifters.
Yeah, right.
So I would first start, and they Valsalva on purpose, right, to do their power lifts. So in the clinic, I would mimic that Valsalva with lighter weights and work up toward that. And then I definitely would take them downstairs. But essentially, most of the things, when you're at the point where you're progressing to sport-specific exercise, you're able to self-assess what your pelvic floor is doing. And so you're able to, and so those people, when they're training, for example, a sit to stand, they're able to tell, I can activate and I can get here and then I lose it. Or I get here and I lose it. So I take them through the movement that they're trying to reproduce and say, where is it that you're losing it? I had a tennis player that would be, every time she could run, she could do all kinds of things, but every time she would activate core for the forehand, she would lose it. So then I took that apart and I said, okay, is it at the lunge? Is it at the beginning? Is it back here? Where is it that you're losing it? And then I retrained them to be able to hold it through the whole thing. And then the challenge is really, how long can your pelvic floor hold? If you can hold your pelvic floor for 2 seconds, that's not going to be long enough to get you through your lift. So we want to make sure that you can hold it for the amount of time that you're going to need that for your sport too. Good question though. Anybody else? All right.
Okay.
Seeing none, I'll end this part of the presentation, and I think we're going to be having another join us in a little bit.